Hi, everyone, and welcome to our session this morning. Today, we have Dr. Smisha Agarwal, and we'll be talking about digital health platforms for COVID-19 case management and contact tracing. Before I introduce her, just a couple ground rules for the session. The usual, please introduce yourself in the chat box, and I believe Smisha will have some questions for you throughout that she'll be asking you to post in the chat as well. If you have any questions for Dr. Agarwal, please make sure to add those to the Q&A function. It's a lot easier for us to track all of the questions there than to track them in the chat. So again, welcome this morning, and we look forward to your participation, and thank you for being here. Dr. Smisha Agarwal is an assistant professor in the Bloomberg School of Public Health and also the research director for the Johns Hopkins Global mHealth Initiative. And again, today she'll be talking about assessing digital health platforms for COVID-19 case management and contact tracing. So with that, over to you, Smisha. Oh, you're muted.
Okay, got it.
There you go.
Great. Good morning, everyone, and thank you for having me, Anna. I'm thrilled to be sharing this this report today with everyone. So over the last few months, our team at the Johns Hopkins Global mHealth Initiative, at the request of the Gates Foundation, conducted a rapid assessment of digital platforms that are largely being used in low and middle income countries to respond to COVID-19. And so during the talk today, I will go over the details of several of these platforms, and I'll also go into the detail of the assessment criteria that we put together to understand how these platforms can be repurposed for COVID-19 response. So even though we focus on 9 platforms that are the most widely used platforms in low and middle income countries, the assessment criteria essentially should help decision makers in thinking about what criteria they should consider if they are choosing any other platform as well. So for example, any proprietary or local solutions that might exist. And so we'll go into that in some level of detail. I have to say that there are a number of technical details during this presentation, which folks may not be quite as familiar with, but if you add your questions to the chat, we can deconstruct them as needed over the course of the talk. So yeah, so let's get started. So a little bit of context. With COVID-19, countries and health systems are facing a situation that are exposing the vulnerabilities in public health infrastructure. Healthcare systems in every country, they're faced with a disease whose risk and protective factors continue to be poorly understood. And public health agencies are scrambling to respond to contain the pandemic, in part through large contact tracing programs that can help notify and track contacts of cases. So this is where digital platforms can help. They can support case management, and they can also support the process of listing, notifying, and monitoring contacts of confirmed cases. We have some evidence from the Ebola epidemic that highlighted that there were several challenges to paper-based contact tracing, which resulted in delays. There were loss of lists of contacts. There was inadequate follow-up on contacts due to the loss of lists, and just a range of issues that resulted in delayed follow-up. So employing digital tools for case management and contact tracing can actually help optimize some of these processes to facilitate timely analysis of cases and contacts and follow up with them. Interestingly, in the early days of the pandemic, which now feels like a lifetime ago, we observed an influx of apps for COVID-19 response, each with a range of sophisticated functions. And not just in LMICs, even in our own state of Maryland here, this was really a paralyzing experience for decision makers who were required to make a really critical decision, an often expensive decision, very rapidly in the absence of complete information. So in an effort to fill this gap, the Gates Foundation requested that we conduct a rapid assessment of digital platforms. That's right here. And so these platforms have an established presence in several low and middle income countries, and they have already been or can be rapidly reconfigured to address COVID-19 related case management and contact tracing needs. So as you see here, we have, I think this is the poll, but we have 9 core platforms that were identified for this assessment. If you have worked with any of these, we would, if you can take the poll, that'd be great. We have an assessment of that. There you go. Great. We have users for most of these platforms. That's great. Okay, so as you can see, we have users for a lot of these platforms here today, and they were really selected based on their existing deployment, their flexibility and adaptability for COVID-19 use cases, and also their availability in multiple languages, or ability to support multiple languages, as well as stakeholder interest in leveraging them for COVID-19. So I am ending the poll here, and I see that about 50%, over 50% of the audience has not used any of these tools. Great. Okay. So let's see. So each of these platforms, on the surface, they might appear really similar, but they are actually optimized for different functions, and they can be repurposed to a range of use cases with varying levels of effort. And I think that's a critical piece, the varying levels of effort, because often when we spoke to the stewards of these organizations and we asked if a certain capability could be built, they said, yeah, sure. But the time that it takes to actually build that, could range from a day or two to several months or longer. So the capabilities can be built, but we assess them on what capability is present as of early June, was present as of early June. So the approach that we followed to do this assessment is we reviewed publicly available demo videos of the platforms, and several of them actually have videos on how they've been adapted for specific COVID-19 use cases. We also downloaded and used the platform so that we can get an assessment of the dependencies, the usability, sort of the barriers to use. They are open source, but often to download it can be really challenging. You have to reach out to the developers and so on. And we also spoke to the platform developers or the stewards to get clarity on various aspects of the platforms. And then we reviewed existing documentation on GitHub and wiki pages. So I am going to speak to one specific use case for this talk, but the platforms can be adapted to a variety of use cases. And so I'll take a minute to just mention them here. So one is COVID-19 case management, which is the one we will dive into. And this is where the application is used to enroll a suspected case, capture demographic information, capture risk factors and exposures, symptoms. If laboratory facilities exist and there is an ability to link to a laboratory, then create lab requests and monitor patient outcomes. This may also be the first step to link to contacts listing, so listing of contacts of the confirmed case. And so the second use case is contact registration and follow-up, where the application may strengthen active case detection through contact tracing activities and follow up with contacts of suspected or confirmed cases. This may be done in person, but it may also be done through messaging, either through an SMS or WhatsApp or through phone calls or other systems of communication. There is also port of entry screening and follow-up, which is actually is being widely used in several countries. This was deployed in several African countries. This was deployed as early as March, when the initial news of the virus in the United States was took hold. And so the port of entry screening and follow-up is an application that can enroll travelers who have visited high-risk location at ports of entry for monitoring and follow-up as per the local regulations. There is event-based surveillance system where there is reporting of aggregate data on individuals with COVID-19 symptoms, maybe those who have a confirmed laboratory test. There is lab test tracking, where the application may link the patient and the healthcare worker to the patient's sample that is sent to the laboratory for testing. In some of the applications for lab test tracking, there is also the ability to provide training to the healthcare worker on how to get a sample for testing. There might also be other healthcare worker training training modules that are being rapidly deployed through various apps. And then there is the last one is the facility readiness and stock tracking application. And so this is to our knowledge, the range of applications that are being most widely used for COVID-19 response. For the purpose of this assessment, we focus on a combination of the first two, which is case management and contact registration and follow-up. So that looks something like this, where we have in the report, which I have linked at the end, we have user personas for these, for the provider and for the patient. But let's say a provider, either at the facility or at the community, registers a patient to the system and queries the patient record. If there is a record, there may be no record to start with. And assesses symptoms, orders lab tests, which may be aggregated and reported to the ministry at some level. There is documentation of detailed history and each close encounter, which may happen either at the healthcare provider level or another provider or a social worker within the area, or a community health worker, for example. And they may provide educational materials to the client. They may monitor health status remotely, and they may update the record based on what the progression looks like. And this piece here is on contact tracing, where there is follow-up with the contacts and updating and querying and creating an individual record for the close contacts of the case. So this is by no means intended to be prescriptive. It is sort of one way in which this might roll out, and different programs may identify pieces of this workflow that might be pertinent to them. So next, I will go over the various platforms fairly quickly, and I'll introduce them fairly quickly and spend a bit more time talking through the criteria for assessment later. So several of these platforms, they have a case management and contact tracing use case that has been built based on WHO's FFX protocol, which is the first few cases protocol, which I think folks have found tremendously helpful in defining the data elements and the workflow very rapidly. And so having a use case built out, so having a particular application for a use case built out, essentially it reduces the time for deployment. So if a government or an institution chooses to adopt a certain platform and they have the use case for, let's say, port of entry screening already built, typically it can be modified with minimal effort to the specific instance of how the government or the institution wants to use it. And so it really reduces the time to deployment. So you'll see that we've focused quite heavily on the use cases that were built as of early June. So ComCare is the first one, and I think it's also one that is one of the oldest and most mature platforms. It has several relevant use cases that are ready to go. It's being used in 30 countries, including the United States. It has fairly good coverage in San Francisco, I believe, and it has over 20,000 users established globally. And essentially, it is an offline capable mobile data collection and service delivery platform that was already in place in several countries at various levels of scale, and it allowed for longitudinal tracking of clients. It has a fairly straightforward application builder. It's highly customizable, and it has, like I mentioned, several turnkey ready solutions for COVID-19. There is Community Health Toolkit, which is an open source platform as well. It's supported by Medic Mobile. And it is a community-owned platform, and the community contributes open source code, design resources, documentation. It is currently deployed in Nepal, Kenya, and Niger. At the time when we spoke to them, the primary use was around port of entry screening, and they had certain case management features that were being planned and built. And they are it's meant largely for a community health setting, and it has a nice inbuilt feature for two-way communication via messaging. Also, one of the platforms that I mentioned earlier is called Rapid Pro, and that's essentially optimized for SMS or SMS communication or two-way messaging. And several of the other platforms integrate with Rapid Pro so that they can build that capability fairly easily. So moving to DHIS2, which is again an open source web-based application that supports data collection. So in our poll, most folks, we had the largest number of respondents familiar with DHIS2. And that's the system that's been traditionally used as a health information system in low and middle income countries for district level reporting at the aggregate level. That's a system maintained by the University of Oslo. The platform that we looked at is DHIS2 Tracker, which is different from DHIS2. It's an extension of DHIS2, and it's basically used for tracking individual level data. It works in some similar way as ComCare as a frontline application, and can be used in a community or a facility-based setting. The benefit of the tracker is that you're not worried about interoperability. You're not worried about how data from individual level records will feed into the health management information system, because the DHIS2 tracker works seamlessly with DHIS2. And DHIS2 tracker has the benefit of being highly configurable. It is deployed in 52 countries and 17 Indian states. It has several turnkey ready COVID-19 solutions. It is one of the oldest and most mature system with a very mature community for training and implementation and deployment of the system. Speaking next about GoData, which is a system that came up during Ebola, and it was supported by the WHO. Essentially, it is an easy-to-use case and contact data collection and visualization, and it offers visualization of disease transmission. And the functionalities for GoData are in case investigation, contact follow-up, visualization of chains of transmission, including secure data exchange. So it was, as I mentioned, used during the Ebola crisis. It has multitude of features that, or rather it is as highly configurable, comparable to DHIS2. So it can be adapted for very specific use cases. And it also has several turnkey ready COVID-19 solutions, as well as very sophisticated inbuilt analytics with visual summaries of cases and contacts and sort of the network that exists. I see that there was a hand that went up, and I will just ask folks to add in questions in the chat. And maybe we can take a pause at the end of this for 5 minutes for questions. Anna, if that's okay.
Yeah, we can do that.
Okay. So ODK is, I think they were called Open Data Kit, but now they go as ODK. It has been used traditionally for data collection. Several of us might have used it. And it was used for survey data collection, but now it has a lot of advanced functionality that does allow for response to COVID-19. It is not, and this may not come across right off the bat as you're looking at the application, but it is not optimized for a health facility setting with longitudinal follow-up. of clients. It is set up for community-based data collection, where there is one point in time cross-sectional data collection about a case or a contact. And Nifindi is the primary steward for ODK and supports ongoing development. ODK, the strength is in its active global community of developers and implementers. And it is so well community owned that there isn't a formal documentation of all of the deployments. One bit that makes ODK really easy to use is that the forms can be created on Microsoft Excel or even on Google Sheets, and they can just be uploaded to the server to create the forms that can be used on a tablet or an Android device. So OpenSRP, or Open Smart Register platform, it was largely built for use by community health workers to longitudinally follow up on clients at the community level. And at the time that we spoke to them, they were in the process of their first deployment for COVID-19 response in Indonesia with local translations. And so they had an app for COVID-19 case management, and actually one of the most sophisticated apps for lab test tracking using some specific barcode technology. And they had a number of additional apps that were being planned. Rapid Pro is, it allows users to visually build multi-channel two-way messaging bots. And it can be run on SMS, WhatsApp, interactive voice response among channels, among others. And using Rapid Pro flows, users can essentially build sophisticated time-based questionnaires or other interventions in a few minutes. We use Rapid Pro. It's so easy to use that we actually do a demo in a classroom environment where students can rapidly build and deploy interventions within a matter of 30 minutes, and even as first-time users. So it is fairly easy to use. It is compatible and can be integrated with several other platforms that I've talked about today. It has also a very large active global community of implementers. Sormas was the other platform we looked at, and it is an open source Android and web-based platform with several turnkey ready solutions for COVID-19 case management, contact tracing follow-up, lab test tracking, and event-based surveillance. It was used extensively during Ebola response. It is currently being scaled up in Nigeria and Ghana, as well as in Germany and Switzerland and France. And so it has fairly high standards for security standards, and has been audited since it's based out of Germany. And so it follows a very sort of stringent set of regulations. And then finally, the last use case, and we can take a 5-minute break for questions, is around is WellTel, which is different from other platforms. It is a virtual care and patient engagement platform, and it connects remote outpatients with the healthcare system via their mobile phones. And so the platform will essentially allow health teams to check in on COVID-19 patients via text message. And they are increasingly building natural language processing capabilities to optimize the process of text recognition and response. But currently they have live operators responding to the text. So they might ask the patient how they're feeling that day, and the care providers can respond with a phone or a video call. The data from the text are abstracted into a health record. So there is a health record on the back end. It is a browser-based interface on a desktop or a smartphone, so it is not an app. And therefore it can be used on basic phones to connect patients via SMS. And so patients don't need to have a smartphone or internet access to be able to do that. It has additional features and functionalities around scheduling and reminders, and that can help, that are also actually linked with the secure patient portal. So that's actually the end of the overview of the platforms, I'll bring you back to the primary use case that I talked about. And that use case is for patient triage, referral for testing, contact listing, notification, and follow-up. And we assessed, we broke this workflow down into several specific components. For example, register a patient in the system, query the patient's record, input demographic information, provide educational materials. And we assess the platforms for each of these specific functions because it is easy to follow what exactly these platforms do against each of these functions. So again, for referral for testing, we explored these, and for contact listing. So it can really help delineate how these platforms differ from each other. And essentially what we found is that all of the platforms have the majority of the functions, but not all the functions. ODK, as I mentioned previously, is primarily optimized for data collection about cases and contacts, one point of contact, not longitudinal follow-up. It has several strengths that can make it the platform of choice. And Rapid Pro is primarily optimized for remote communication via messaging. Okay, so I will stop there for questions. Anna?
Sure. Would you rather take a question from someone with a raised hand, or we have some in the chat box already?
Maybe, actually, let's go with the chat, if that's okay.
Sure. So Stephen Yoon asks, were surveillance requirements considered for the assessment?
Surveillance requirements. So we did consider, I guess the surveillance requirements would differ for each country, but what we considered is essentially listed in this part of the report. And so we did consider the types of functions that would be needed for contact tracing and for reporting aggregate data for surveillance at a district or a national level. Again, those might differ by country.
All right, so then there are some questions about specifically using these in LMIC contexts. So I'll start with this question about poor penetration of mobile networks or electricity. What strategies are available to enable the use of app-based approaches for contact tracing, tracking, and case management, particularly in rural settings?
Yeah, so I will discuss that in quite a bit of detail in the next portion of this presentation. But essentially, no platform is perfect in and of itself. It needs to be considered against the environment in which it needs to be deployed, and we do have certain considerations for low connectivity environments that I will get into later. Also note that the apps and the platforms that we're talking about are distinct from what we hear in the news media about Bluetooth enabled contact tracing, which might work well for urban settings with that kind of connectivity, but may not work well for rural and peri-urban settings in LMICs. But healthcare workers can be connected to a mobile device. And I'll talk a little bit about how in those settings data transfer can happen.
All right, I think a lot of the questions really are thinking about, at this point anyway, are thinking about how these can be used in these types of settings that might have different regulation requirements, or that might have lower access to connectivity, and how you can do these things offline. So I think unless you want to take some questions from people with raised hands, then perhaps you just keep going.
Maybe we can, yeah, and I see the questions, and I will address them in the second half of the talk. So we can take a question or two from folks with raised hands.
Okay, so I see Halida has a raised hand, as does Jai. And so anyone who wants to start talking, please feel free. Or Megan, perhaps you can unmute someone. Oh, please go ahead.
Jai can go ahead. Yeah, I think I don't have any specific questions. Sorry about that. Yeah, okay.
Smisha, my question was whether the feedback from the community of users, the actual users in the field, was taken as part of the assessment Because one thing is reviewing what is already out there, or probably working together with these providers. But then, like, has it been taken? The feedback of the users have been taken as part of the assessment? Is my question. Thank you.
So in a different format, we did consider usability criteria, and I'll go into that actually in the second half of the presentation. And also, we actually went into a fair level of detail, Jay, about community of developers, community of users, community of folks involved with deployment through the GitHub and wiki pages. Since a lot of users are providing information about bugs and downtime online. So we did go into that. So actually with that, maybe I will actually move us to the next part of the presentation, which is looking at selecting an appropriate platform based on the context. And so, like I mentioned before, these platforms, they appear to have a lot of similarities. And as you can imagine, it's incredibly difficult to make sense of what would work optimally for a given context. So ComCare, CHT, DHIS2 Tracker, GoData, OpenSRP, SORMA, Swelltel, they have all been used in low and middle income countries. And so the concerns about sort of rurality and peri-urban area use, they have been considered in using these, right? Other aspects are the type of mobile device that these systems work on that might determine what works best for a specific system, whether they have messaging functionality, and then Pranav, as you mentioned in the chat, around low connectivity environment, because there are challenges with how data can be transferred. And we looked at aspects of transfer via Bluetooth, as it is a function that tends to be desired in low connectivity environments. So we assessed a lot of these criteria. They're called non-functional requirements on a maturity scale of 0 to 2, with 0 indicating that a functionality does not exist and 2 indicating that it does exist and it's fairly mature. And so this is the list of non-functional requirements. It's a fairly detailed list. I think it captures pretty much, in my quick review of the chat, all of the concerns that folks had about how these platforms might work in LMICs, and I'll go into them in a little bit of detail over the next few minutes. And so, Jay, to your question around usability, we defined a number of objective and subjective criteria to think about how intuitive the platform is to use from a user perspective. We also downloaded it on our end and worked through it and reviewed wiki and GitHub pages to see how users were engaging with it or where some of the bugs were. And so these are the list of criteria. And overall, our assessment was that the user interface for most of these platforms, given that they are actually built for LMIC environments, they are fairly easy to navigate. And DHIS2, ComCare, and GoData, they are highly configurable with multitude of options, which is great because it makes it, in some sense, easier to use, but it also, I think, can require it can require a lot more troubleshooting, because you can get into more challenges that have been previously unexplored or not discussed in the community chat rooms. Also, these platforms they can be used in a number of languages already. GoData, SORMAs have language packages, which means easy translation is possible. Several of the platforms that are open sourced and community supported, the translations are done by the community, and even in certain sort of dialects, translations might be available. These platforms also have documentation, training, and other support. So documentation is a hallmark of how mature a software is. An adequate, updated, clear documentation, it can facilitate easy installation and customization of the software. So all of these platforms, they do have standard user and technical documentation available. There is support either through the platforms stewards or by the community for installation and customization of the software. I will talk a little bit more about that, because several platform stewards are actually So typically, support for customization and installment is through a fee for service. It might be, if it is an open source platform, through service level agreements possibly. But in the case of COVID-19 response, some of these services are being offered free of charge, though I think our assessment has been that they're not as openly advertised because there were concerns about folks being overwhelmed with these requests. So if you're considering them, I would say it's a good idea to reach out to folks and see if it's possible to have support in customization and deployment. So open access, which essentially means that the software code is free to use and change and distribute. It does not mean that the platform is free to the user, however. And I think that's often misunderstood, we have observed. And so from an implementation perspective, it is important to realize that it can be very challenging to adapt the software if there is inadequate documentation and also if there is no community around it. So depending on the maturity of the developer and user community around the platform, new use cases may place a heavy burden on the team that's undertaking the customization for the first time. Of course, open source has several benefits. The system can be stood up rapidly, adapted, and owned by the implementation group, and possibly at a much lower cost. So we really looked at the development community for each platform because we wanted to move beyond them just being open source. We wanted to think about whether they do actually provide support for customization and adaptation. And most platforms assessed here, they do offer fee-based support to customize and maintain the system. So I have the names here, but all of the platforms except WellTel are open source. WellTel is proprietary, and GoData is intended to have open source code, but it's not currently available. And so if you reach out to the GoData team at the WHO, they're able to provide that information. And we found in our interaction with these groups that they are eager to help support. They were definitely very supportive of us doing this assessment, and were helping us along the way in providing relevant information and reviews of the documents. DHIS2 Tracker, ODK, and Rapid Pro from our assessment had the most active global implementer community. And so they've really invested heavily in growing the developer community. DHIS2 has the Tracker. The parent organization has several training programs to facilitate that kind of training within governments. So reliability is typically thought of as whether the ability of an application to run consistently without failure over time. In case of failure, there needs to be regular backups of the data available to restore the system to normal functioning without loss of data, or there needs to be comprehensive disaster recovery plans. All of the platforms actually, they could be deployed on the cloud. That means there is some backup and there are disaster recovery services in place. We wanted to look specifically at how these systems function in low connectivity environments. And you'll notice that in the definition of a lot of platforms, they mention that they are actually offline compatible and so on. And that's fairly complex because no platform is truly 100% offline, functions in an offline environment. Those limitations stand, but there are some ways in which they can be addressed. And so we looked at two sort of typical challenges of an offline platform. And since there were a few questions about this, I'll dig into this a little bit deeper. So typically, when, let's say, a healthcare worker at a community level is entering data about a client, that information can typically be stored on the device on which it's being collected. And if network connectivity is available within a short distance from the end users, the platforms can upload the data to a server locally or onto the cloud. But in the absence of a constant, reliable connectivity, there has to be another way to upload the data. And it might be through a local node, let's say a laptop in the hand of a supervisor. So a healthcare worker can collect data about, let's say, contacts or in a village which is not actually well connected, but when they go to the nearest healthcare facility or place that's less rural, they might actually be able to use USB or a Bluetooth connection to synchronize the data and upload them to the server. And so that aspect is still being built out. And ComCare and OpenSRP have one or more instances where this peer-to-peer Bluetooth data transfer has been used. One other issue of offline connectivity is, let's see that multiple healthcare workers are working on their tablets or devices in an offline environment. Patient IDs, in the absence of official national IDs, are randomly generated. So how would they generate patient IDs and upload the information without duplicating patient IDs? And most of the platforms do actually have solutions to deduplicate patient IDs or to randomly allocate patient IDs. So for example, they may have pre-allocated 100 IDs to each healthcare worker, so there is no risk of duplication of IDs. And so this is fairly technical, but just to get at the weeds of what this offline connectivity entails, right? So those features are definitely addressed. They're not 100%, but they are pretty solid as it stands. And there are, of course, options to connect to a number of external devices that can facilitate connectivity, which we didn't explore here since they're not core to these platforms, but depend on external hardware, essentially. So moving on into scalability, several of these platforms are fairly scaled. ODK hosts over 80,000 users, DHIS2 Tracker hosts over 43,000. And this is in a single instance, but across countries, they may have several more users. Standards, interoperability, and data accessibility. So there is a push that systems do adhere to global norms and standards around the way in which data are captured, stored, exchanged with other systems. And over the past decade, actually, a number of digital health architectural standards have emerged. You may have heard of HL7 or FHIR, and they help data to not only be stored with optimal efficiency, but also for data to be exchanged across different ecosystems of tools and solutions using the same standard. And the platforms do comply. The platforms that we looked at here, ComCare, DHIS2, ODK, OpenSRP, SORMAS, and Beltel, they do comply with industry standards for healthcare data exchange. The compliance with ICD-10 or other sort of health exchange languages is lower, and I think it's also far more complex because these platforms do operate in different country settings where adherence to some of those standards within the healthcare system is quite variable. So moving next to devices and operating system, and I've put a screenshot from the report here, noting that so each of the features that I talked about up to this point, we've actually, there is a similar assessment for all of them broken down into component parts for all the platforms. But since this is one that folks tend to be quite interested in on what types of phones do these systems operate on, we see that most mature global offerings, they cater to the dominant Android operating system, and they can leverage a wide range of user-held devices. Some of them do support basic phones, right? And they do support feature phones. But I note that the functionality tends to be a lot more limited if basic or feature phones are being used, given the obvious limitations in the user interface. So text messaging is, of course, an important form of communication between healthcare workers and the healthcare system and clients. Especially in the context of COVID-19, text messaging could be used by healthcare workers to report to supervisors or to the healthcare system about suspected cases. We saw that a lot during Ebola response, and also then to follow up on cases and contacts to assess where there has been onset or change of symptoms. So SMS is, of course, the standardized way in which text messages are shared. And it is important to understand if a platform supports one-way messaging from a healthcare worker to a patient, or two-way messaging where the patient's able to respond through the same channel. There are also options for in-app messaging. If there is an app, then the patient is able to communicate with the client through the app. And now there is increasing use of WhatsApp and other social media platforms for messaging, though those are, especially social media messaging, it is dependent on data packages and on use of smartphones, and so they have limitations. And so I would say that Rapid Pro does have one of the most advanced capabilities for SMS-based communication. It integrates with several other systems, and several other systems here have experience with integrating with Rapid Pro to make that, to facilitate that two-way communication. And so security, I believe there was also a question about that. All the platforms have out-of-box authentication, authorization, and data encryption, and some have been audited by external entities and have more stringent security protocols in place. So analytics, and all the platforms provide either advanced inbuilt analytics, or they have the ability to integrate with an external software such as R or Tableau. And they provide dashboards for mapping, for graphs, tables, multi-level filtering to various levels of sophistication, where you can see distribution of cases and cases and contacts by certain districts or even certain clusters. And they provide the ability to actually download the data as a CSV file, and so it can be uploaded into external analytics tools. And Welltel is notable. I mentioned that they are in the process of integrating natural language processing in their workflow, since their workflow is entirely messaging based. And finally, in these criteria, we're talking about cost considerations. So most of the applications other than Welltel and GoData have free open source licensing. So that means they can be independent, they can be deployed independent of the implementing organization. That is, if local consultants are available and have the expertise to adapt them fit for purpose. However, if local expertise is not available, then the steward organizations that are hosting these platforms can provide the support for a fee. So specific to COVID-19, as I mentioned earlier, these services may be available free of cost or at a highly discounted price. And so ComCare, CHT, ODK, GoData, OpenSRP, SORMAS, they all have open source licensing. And Rapid Pro and DHIS2 are open source, and the steward organizations they provide advanced troubleshooting support only, since they have fairly established communities. In the report, you will see a breakdown of what the tentative costs for these platforms look like, to give you a little bit more sense of where things are headed. And so finally, to sort of wrap up, the criteria that I presented so far was fairly objective in how we looked across the various platforms. We also pulled together some high-level features that folks tend to have concerns around, and put them on the scale of 0 to 3, and where the dark green stands for the most advanced functionality. And you'll see that there is actually, for platforms that seem on the surface of it fairly similar, quite a lot of variation based on ease of use or active developer community, adherence to standards, sophistication of built-in analytics, two-way messaging, multilingual support. And also, given how the ease of deployment and the speed of deployment, how turnkey ready these platforms are for COVID-19 response. So from our assessment, DHIS2 Tracker and ComCare were perhaps the most stand out for their maturity and flexibility in large-scale deployments. They have a number of turnkey ready solutions for a variety of use cases, and they have a proven success with large-scale deployments. But like I mentioned earlier, that it isn't a one-size-fits-all. The decisions to adopt a particular platform really should be made starting from what the ecosystem requires, or what the needs of the country are, or the context are. If there is interest in remote communication with healthcare workers, then Rapid Pro can be recommended for messaging only communication. So I'll stop there, and we can, this is the link to the report and my contact information, and happy to discuss any points or questions.
Great, thank you so much, Smisha, for that presentation. I think a number of the questions that were posted earlier you answered throughout your talk at the second half. There's one question that came up really early, though, that I think would be interesting to explore. So someone noted that there's limited flexibility for introducing new technologies at this point in time, since many states or governments started developing platforms months ago and have been using them. So how do you think results from this report could be used and leveraged to promote digital tools that really meet the needs of our participants or of different users?
Yeah, so I think several governments, of course, have local solutions that are built and scaled. Most of the solutions that I know of, they tend to be quite heavily focused on use of some kind of Bluetooth, or require sort of a large number of users for a good amount of uptake for it to actually be used. So for example, the most common sort of technology that also is being widely used in India and is helpful given the concentration of the population density has to do with geographic information, or checking into certain places to see who your contacts are. And they have their use, and they should be scaled up. They also have their limitations. I think this specific report does speak to a very specific use case of case management and contact tracing. Again, it can be broken up into different pieces if it's helpful. I agree that this is probably not the perfect, the time to test new technologies. Having said that, I see them being tested. There are a lot of new technologies that are being tested because they sound good. In which case, I think the report, the assessment criteria, and sort of the analysis of how we can approach a selection is what's most helpful. And so we're by no means promoting these 9 platforms, if that helps. I think if there are proprietary solutions, or if there are local solutions that are being developed by governments, this can provide as an aid to just choose between those available solutions.
And so what do you see as the next step for the Hopkins Global mHealth Initiative based on findings from this report? And how would you like to see the results used?
So we're still, I guess we've had quite a bit of interest from users as well as from the donor community that's trying to understand where they should be investing, in what type of platforms and solutions they should be investing in. And so we're still in the process of disseminating this report. And yeah, so I guess if there are sort of any questions, we'd be happy to talk through them. There are, of course, a lot of observations that I think didn't make it into this report. And so if there is if there is an intention to use it in any way, we'd be happy to have a chat about it. And I don't know if there are others from the team on this call. Maybe Alan's on the call and would like to add to that.
Yeah, Megan, could you open up the microphone for Alan? I'd also invite, Stephen Yoon has been asking quite a few questions about the report. And so also, Stephen, if you would like to open up your microphone and have a chat with Smisha and the rest of us, please go ahead.
Yeah, thank you. First of all, this is an amazing presentation, and I think the interactivity with the participants has just been fantastic. We've literally just released this report, and so all of your feedback is being integrated and leveraged in our thinking and ongoing conversations with, as Smisha mentioned, funding agencies who are supporting a lot of this work in countries, but also with government stakeholders through WHO, who is also getting ready to launch a clearinghouse for technologies and software, not specific to COVID, but including a large domain for COVID technologies. So stay tuned for that piece of work from WHO. But as we've been discussing in the chat box, clearly, you know, this entire pandemic has revealed so much about the level of preparedness, not just in the technology communities, but public health writ large. And hopefully we have a lot to learn moving forward. The indicators and the use cases that the team developed here are really worth taking a close look at, especially to leverage as a source of or a structure to evaluate other platforms that may be out there, and we hope to be adding to those use cases as well in the near future.
Smisha, anything you'd like to add to that? Okay. We can thank you, Alan. We can also, Stephen, if you would like to open your microphone, we can give you the opportunity to talk as well.
Good morning. Thank you. Actually, I don't. I've asked a couple of questions. I think this work is really important. In fact, at CDC, we have just done something very similar, and you know, it's good to see that several folks have already identified this particular gap and have you know, worked on addressing them. So perhaps there could be a follow-up conversation offline to see whether there may be opportunity for us to collaborate. Over.
Great, thank you. So again, Smisha, I think you answered so many of the questions that are already posted earlier in your presentation. Are there any final thoughts you'd like to share before we end today's session?
So yeah, I guess just the final thought is that we were quite sort of selective about the platforms that we looked at for this report, in large part because of the need to be able to do this rapidly and with a level of detail and thoroughness that's actually useful and helps delineate the differences and the strengths of the platforms. The platforms that we've covered are the ones that are already in place in several countries. There is an interest from the governments expressed to the foundation that they're interested in scaling up and using. And however, if those are not the platforms that you're working with, I would recommend that reading through the second portion of the report that provides some insights on how to approach selection of platforms and how to approach selection of a technology can be really helpful. It's something that working actually in our state of Maryland, we really saw decision makers grapple with. And so hopefully this helps shed some light on that, and feel free to reach out if you have questions. Thank you everyone for joining today.
Great, thank you so much, Smisha, for your presentation, for reviewing the report, for answering all of these engaging questions, and everyone, thank you for attending. Our next session will be next Thursday, and we look forward to seeing you there. Thanks so much.